Research has shown that basic knowledge about our health in the Gambia is poor. One of the contributing factors to poor health is people's lack of knowledge about their health. QTV brings you a weekly health program called Werwerle. Every Wednesday at 8:30 p.m., the show will look at different health issues.
I used to hear voices around me, and later when I hear the voices around me, and then I have to report to TankaTanka, That's the only problem I have.
This is Aliu, a patient at TankaTanka that suffers from schizophrenia. For legal and privacy reasons, we can't show Aliu's face. Hello and welcome to Where We're. In today's program, we're going to take an in-depth look at mental health. TankaTanka is the only psychiatric hospital which is under the Edward Francis Small Teaching Hospital, the only provider of psychiatric services in the country. So we think it is only appropriate to pay them a visit. So when you say you have voices, that means you do what they call hallucination. Yes, but do you take medication to help you with that?
Yeah, I take medication, but immediately after TankaTanka here, I run off medication, but I should continue, really, yeah. But I promise this time, yeah.
Ali, you are a young man to me. Do you mind if I ask, what were you doing before your 5 years admission in TankaTanka? What were you doing outside?
I was doing music industry, and my artist name is Peacemaker. They know me. Adimeka, they call me.
Okay. So, Peacemaker, do you still have your songs that you think of or write when you are alone?
Yeah, I have enough song, because I even shoot a video 2010, me and Warrior. Warrior is in German, and there was a song called Oh Mama. Oh Mama, Mama, me love you.
That's like my song because my name is Mama. That's great. So basically, they say music is good for the soul. So what time do you have? Do you normally, I guess you have family outside of TankaTanka. Do they come to visit you?
Yeah, of course. Even yesterday, my family was here, One of my bro.
Okay.
Yeah, he was here,
They say that in Gambia, when it comes to mental health, sometimes people are not very supportive. In fact, when you feel you're not okay and you go out of TankaTanka and you go back to society, they tend to make you feel worse and you have to come back. Do you think that's true?
No, to me, that's not true. But because what is the problem? I thought is women are disturbing me because me, I'm worker. Me, commission artwork I do. I'm artist. I design. You just talk to me what you want. I bring it live. Yeah. Okay. Yeah. Any artistic work, me, I can do it.
Okay.
Yeah.
So like banners or flyers and stuff like that.
Commission. That's mean artworks. It's like cement work. Artistic. Painting. Any kind of painting. Like flower pot. Creative. Bring it live to make it easy. Yeah. That's what I've done,
So, Ali, if you don't mind me asking, what do you think was the cause of, can I call it a sickness? When did you start realizing that you feel sick to come to TankaTanka?
2016, I think so, yeah? Mm-hmm. Yeah.
Did you just get up and think, I need to be admitted, or do you have to go to the hospital?
No, I don't even think so. I have to be here because they take me to Senegal, After Senegal, after my people brought me in. So, but I was not thinking of coming here. Yeah. Yeah, after being in Senegal, they bring me in here, Yeah.
Okay, so Ali, where do you see yourself in the next 5 years to come?
Bigger. I have to be in maybe Brazil or America, anywhere. Next 5 years, I have to hit the world by music,
Okay. Can you give me one a cappella before we go, if you remember just some words?
Yeah. Please be my love, all night I think of you. Baby, please be my love. You can make me feel fine. Bigger.
Thank you.
Okay, good afternoon, everybody. I am Fode Jawla, an RN General and also BSc, specializing in psychiatric nursing. and currently I'm the acting matron of the hospital. In the sense that I'm the one overseeing the welfare of the hospital as at now.
We're specifically looking at mental health issues in the Gambia. So if you were to describe mental health as a matron in TankaTanka, how would you describe it?
Okay, that's a very good question. Mental health, as we all know, is the health of an individual, in the sense that if we are to consider somebody to be mentally health, is somebody who is able to cope with normal day stressors, and the individual is able to function in all sort of situations, irrespective of the demanding of that situation. The individual is able to cope with friends, families, and the individual can also cope successfully in the society. In an essence, this is what mental health is all about.
So sometimes people do say that it may range from being depressed to psychosis, if I'm using the medical terms here. So if I'm going by the patients you've got in TankaTanka, which category would you say they fall into?
Okay, that question is basically talking about the mental disorders, because we have a mental health and mental disorders.
Oh, please clarify for me.
Yes. So mental health, like I defined earlier, is the ability for an individual to cope with normal day stressors. The person is able to deal with friends, families, and relatives successfully, and the person is able to function successfully in the society. And mental disorders is the other way around. If someone has a mental disorder, he or she is unable to cope with the normal days stressors, and the person has an impairment with the relationship with families and friends, and the person cannot work productively in the society and at workplace. So mental disorders is a big umbrella. It comprises of so many disorders. We have schizophrenia, we have a depression, we have a bipolar, we have a mania, we have alcoholism, we have drug-induced psychosis, we have childhood disorders as well, which are autism spectrum, we have attention deficit hyperactivity disorder, we have a conduct disorder. But most of the times, cases that we admit here, those are schizophrenia, depression, we have alcohol-induced psychosis, and drug-induced psychosis. Sometimes bipolar and mania sometimes. So these are basically the common conditions that we admit here. Yeah.
Normally, it's a good thing that you actually were able to differentiate both, because sometimes there's that common mistake, like I made myself, I must admit. But when we come to the bipolar disease, for example, is that behavioral? Can you please explain that a bit?
Bipolar, when we talk about bipolar, is a combination of a depressive episode and a manic episode. So it's like the individual or the person has two problems or two conditions combined in one. The person can have depressive disorders at this point in time, and the next minute the person has a manic episode. So during manic episode, the person is hyperactive, very restless, and trying to roam everywhere, very abusive, and sometimes can be threatening to colleagues. And when we come to bipolar, or when we come to depressive episodes, you have the person has signs and symptoms of a classical depression. The person will be moody, very lonely, lack appetite, lack pleasure in the previous pleasurable activities. The person will be lonely. So, but it's like in certain conditions, there are different conditions, but bipolar has these two in one, manic and depressive disorder. Yeah.
Who are mostly affected by, who are the people, like, are they men or women that have bipolar mostly in TankaTanka?
TankaTanka, I can say we have almost the same ratio, male and female. But the predominant cases that we have here are schizophrenia, drug-induced psychosis. Bipolar, sometimes we have about not quite often. Yeah, not quite often. But the prevalence is equivalent both among male or female patients. Yeah.
Relating to the drug-induced psychosis, is it fair to say that's among who, the young people, young men?
That's correct. It is predominantly young people, because it's like most of the time these psychiatric conditions, they run in families, but interestingly, sometimes you can see the whole family, the lineage itself. You will find a patient whose lineage there is no history of a psychiatric disorder, but due to the drug intake, they can sometimes manifest these psychotic symptoms, and that will lead to their bringing him there. So it's like those people, they don't have any family history of psychiatric disorders, but it is as a result of taking drugs. That's why they end up developing these psychotic disorders.
And when you're talking about drug, we are not talking about pharmaceuticals. Are we talking about cannabis and
this illegal? When we talk about drug, if I say drug induced, for the layman, it might be any other drug, but specifically these are illicit drugs. But most common ones in the Gambia here is cannabis, marijuana, most of the time. Some with cocaine, but those things are very rare. The predominant one that we have here are marijuana-related drug-induced psychosis.
Coming to the order, I don't know if it is a fair way to put it, to say schizophrenic. Would you say that would be the most severe form of mental disorder?
Yeah. It is the severe form of mental disorder and most troubling, because most of the time patients with schizophrenia, the likelihood for them to get proper recovery is very minimal, and it is very troubling, because patients who develop a schizophrenia, we've seen them coming in and out. So it's like they are within the community and the hospital. So they are coming in and out, in and out. So it's like among all these psychiatric disorders that we admit here, schizophrenia is the most disabling part of it. Yeah.
So would it be fair to also say, like, sometimes I walk down the Serekunda market and I do meet young men, sadly, who are, half dressed, walking around. Would you describe them as being schizophrenic?
Some of them are schizophrenic, because most of the time for drug-induced psychosis, to our own observation, most of the time they are very violent. Some are very violent, but for schizophrenic patients, notwithstanding, some can be violent, but most of the time, those that you see roaming in the street, most of them, half or three-quarter of them are schizophrenic patients. Yeah.
And they do have the hallucinations, and obviously
hallucinations are common among these conditions. Like we have auditory hallucination, that is believing that they're hearing something. We have a visual hallucination, thinking that they are seeing something that others are not seeing. We have olfactory hallucination. They might think that they are smelling something different that others around them might not be smelling. We have also gustatory, which is a funny test. Some can be very adamant that they have a test that is disenabling them, or that is really disturbing them. We have tactile hallucination as well. Yes, that one, they believe that insects are crawling on their body. So in such cases, no matter how much you try to convince them that what they are thinking is not actually the thing that is happening, is difficult. So in most cases, if those things happen here, we have a different means of convincing them that what they are actually thinking is not the thing that is happening.
That actually brings me to the next question I was going to ask, because if you've got a patient that has been brought here by the family or the society, if that's another way, what do you think, apart from the sickness being inherited? When I say inherited, like you said, the lineage, you come talking about schizophrenics here, being in the family. And what are some of the other reasons, apart from the drug-induced psychosis? Because sometimes I get rumors and stories about people saying he was in Europe and, he sent some money and the family did not buy a house. So he got here and just totally lost it. Do you hear that?
Very good. It's a very important question because when we talk about mental disorders, the etiology or otherwise called the causes, we have a broad range of causes, ranging from biological. We have a biological. We have psychosocial. We have environmental or socio-cultural. All these things play very important part in the development of psychiatric disorders. Some can be free from biological causes like inheritance, because some in the family, if there is a mother or siblings who has a mental disorder, there is a likelihood that the individual will develop. But some in their biological aspect, they are free from developing mental disorders completely. But if you come to psychosocial aspect, maybe the stressors, the life events or the disappointment and the tragedies within the individual's life can predispose the individual also to develop these mental disorders, like socio-cultural, like lack of employment, marriage disharmony, loss of parents, all those things. So it's like these three corners or these three areas come together to develop these psychiatric disorders. But notwithstanding, each of these aspects can predispose someone to develop these mental disorders.
Okay. And sadly, when someone reaches that stage and has to be brought in, I believe you obviously work with the Edward Francis Small Hospital, who do they refer them to here?
Yes. So the referral system, I should have walk you through the system that we operate here. The psychiatric service in the Gambia is divided into three sections. We have the outpatient department, which is at Edward Francis Small. We have a community-based team, which goes around the community to render service to our patients. And also we have our inpatient, which is TankaTanka here. If patients are coming here for the first time to be admitted, they have to go to Edward Francis at the polyclinic to be seen by a psychiatrist, because unfortunately we don't have any psychiatrists sitting here with us. So it's like ideally it is the psychiatrist who should assess them and prescribe medication for them and also determine their admission. So from there, if the patient's condition warrant admission, the psychiatrist will recommend for admission and they will be sent here. So for the community mental health team, initially, but now unfortunately the system is not very functional. But when it was really functional, even the workload here was very minimal, because at the end of every month around the Greater Banjul area, they go around, meet our patients. Those who need supply, they will supply them. Those who need to be advised to go and meet their appointment, they will be asked to go and meet their appointment. And also those who are manifesting signs of relapse, they will be advised to see the doctor before they actually get relapse. And the inpatient here, we have a capacity of 100 patients. Sometimes we do admit more than 100, sometimes below 100, but the capacity is 100 patients. So every Tuesdays and Thursdays, the psychiatrist will come here to assess the patients. So the nurses will determine patients whose conditions are a bit better. We identify them to be reviewed by the doctor. The doctor will discharge some of them, adjust some their treatment, and also recommend them to continue with the treatment. Yeah, so basically that's how the system works.
As resident acting matron, it must be hectic having to deal with a whole lot of cross-cutting issues in that sector of work you're doing on a daily basis. How does it go for you?
It's too hectic, like you said, because managing a whole hospital, especially the only hospital that provide a specific service, is very challenging. And most of the time, issues that we have here are beyond my control, because it's like I'm a representative of the main hospital. So some of the decisions I cannot just take them. I'm also representing the main hospital. So it's like bureaucratic issues. If they come, I have to follow the channel. So before realizing what I actually need, it takes time. And also the workload here is very demanding. Yeah.
That is obviously natural, having to do with a human being, and especially someone that needs special care would definitely be demanding. So, what are some of the other constraints do you have, when it comes to, matron and patient, I'm referring to medication, uh, sanitary stuff. Do you have issues like that in the hospital here?
Yeah, for the medication, yes, we have an issue with medication because it's like the amount of medication that what we need compared to the amount that we get in return is not sufficient to take care of the patients that we have here. That's why sometimes we have this problem of long staying at the hospital, and ideally the place is only ideal for acute cases. So it's like patients should not be kept here for quite a long period of time. But it's like most of the time you cannot also discharge them if the condition is not improving. So it's like if drug supply is not constant or is not sufficient, it's always an issue for us here. And many a times we have such cases wherein we run out of medication or we have a minimum amount of medication. So it's like instead of giving patients the medication that they require, we have to manage what is available so that prolong their stay here, because they need to have a constant supply of medication in order to get rid of these psychotic symptoms as quick as possible so that they go back to their respective places. And also the other problem that we face in here is the problem of family members, because it's like no matter how much we do here, we only spend little time with the patients. The greater part of the care is done by the family. So if the family is not playing the active part, it's always a problem. Because what we realize, you will have a patient here, admit them, successfully being treated. If you discharge them within a month or weeks, you see them back here. So
Somebody did mention that's like basically the social aspect of things is very key to helping the individual be stable, not to get relapse into that.
And one thing the population tend to hold, that means normal people like you and me, if we misbehave in the street or if we misbehave in our respective compounds, nobody give a damn to such things. But a person who recover, not fully recover, the moment they start to even sway aside, they will associate it to their condition. So it's like they are not even comfortable staying with them. So it's like some even fabricate stories against a patient just to convince us that this patient is threatening at home. We have to keep them here. On the whole, patients, they are just not they are as free as any other person. So it's like the family concept towards the patient and their unwillingness. Some are very trying very hard, but some their unwillingness to stay with their patients, keep their patients remain here for quite a long period of time. Because sometimes we have a patients here who've been here for years, not even 1 year. If you call the family to come and pick them, it's always a problem. They will tell you all sorts of stories. And we feel that family involvement is the key for our success. Otherwise, we will be working here for the rest of our life. We will never achieve our goal. So whenever I have such opportunities, I would like to implore family members to take a greater part in the care of their patients rather than leaving the care at the hospital level.
But in a case with medication, what can someone do? What's the other solution apart from just managing?
Yeah, I think the solution should be the inclusion of the medications that we use here into the essential drug list of the country, because it's like we cannot be depending on the donors forever, because the guy who built the place is a Dutch foundation sort of. They're trying very hard, and on top of that, there are so many groups who are coming here to render assistance. We are so grateful to those people. Every now and then we have visitors here to be giving our patients with these sanitary materials, food stuff, and the like. That's not a problem. But medication is a daily requirement. So for us to have a constant supply of that, it will be very good. So we trying very hard. I still need to push that. I should make those on authority to let them hear that we have an issue with medication problem here, because like I said, we cannot depend on donors for our medication. Yeah. So I'm doing that gradually. So I don't know what will come out of it, but we are really pushing to ensure that we have a constant supply of medication here.
Hopefully such programs will create more awareness to just, reach the right people. I cannot talk about mental disorders or mental health because you've mentioned epilepsy, autism, I think it's ADHD also. You've mentioned a lot of disorders that sound familiar to me. Some might be even closer to home. So looking at Gambia, I was reading a report on the mental disorders, drug-induced psychosis and epilepsy. I think epilepsy, this report I think was, I can't put it, I can't put a date to it, but I think some years ago, or 2010 to 11, someone wrote a report. This guy is from Nigeria. It must have been a medical individual that was writing something about mental health and mental disorders in Gambia, and they quoted TankaTanka and RVTH at the time it was called. And epilepsy was at the top scale of, where they were talking about epilepsy almost where you got 648 cases. Drug-induced psychosis might be 40. So do you have cases of people that are admitted here and they also suffer, they suffer from epilepsy, so to speak, but people don't really look at them and say it's mental health? Some people will say, oh, they might have been obsessed by jinns and,
Yeah, that's the problem, because if you say there is this controversy with regard to epilepsy, something that is not mental disorder, something more of a neurological disorders than. But in most of these modern days psychiatric hospitals, you have mental and neurologic disorders hospital. So it's like maybe people's perception towards epilepsy might be as a result of having low cases of epilepsy at the hospital here, because people believe that, like you said earlier, people believe that epilepsy is caused by possession of genes and the like that. So most of the time, even we have such cases, the family will end up coming here to reclaim them, to go and seek for other means of treatment instead of continuing with treatment at TankaTanka here. Yeah.
Okay, so what advice would you have to say to anyone that's watching this special program on health matters about how to really work with people like yourself and other medical individuals that are here trying to assist with people with certain disorders?
Okay, the advice, I will be brief, because first of all, mental disorder is like any other disorders, any systemic disorders, but people's perception may be due to lack of inadequate knowledge or their awareness. People with diabetes, hypertension, cardiovascular disorders, they are living happily with their families at home. So unless people see mental disorder as any other systemic disorder, there still will be a very big gap in the treatment of this patient. So all what I am urging from the audience is that mental disorder is like any other disorder. They need sufficient amount of time. They need assistance like any other person in their family who has any other disorder. And also the issue of family involvement. Families should try by all means to play a very active part in taking care of patients with mental disorder. Because like I said, time that we spend with them is very minimal. They spend the greater time with their family members. So if the family is not ready to take that time, it's always a problem. So I will implore every family member who has a patient who has mental disorder to please see them as any other patient in their family, and stop this idea of stigmatizing them. They believe that once you have mental disorder, you will forever remain with mental disorder. That's a fallacy. Many believe that, but it's not true. We have patients here who have once time been admitted here. They are very productive in the society now. The only thing is the support that they need. That's what they lack. And also the drug. Because many a times, if they are very stable with the drug, the moment they stop taking their drugs, they will have relapse. And what we realize also, many have this feeling. You will be taking drug for an extended period of time. You will feel that you are better without consulting the psychiatrist. You will just decide and go off without medication. So after some time, they will develop a relapse. So what I'm advising the populace is that anyone watching this program, if he or she is a patient himself or has a relative who is a patient, their support is very vital. Medication is also very important, and let people have this feeling that psychiatric disorder is like any other disorder. They can be treated, and now the person can still be functional in the society. Yeah, if people believe and take this thing into consideration, we will have less cases of those you see roaming in the street, because they all have family members. It's just sad that the assistance that they need from the family, they are not getting it. So all that we need is for us to take active part in the management of our patients, and throw away this idea of stigmatization, treat them like any other human being who is suffering from any other condition. With that, the condition will be abated. Yeah.
Mariama, yow patient nga fii si TankaTanka?
Waaw, patient si TankaTanka laa fii. Na fii laa doon job na fii laa doon liggéey.
Yow nang doon liggéeyee fii?
Doon liggéeyee fii.
Yow nga ne ñaata at nga fi nekkoon di liggéey?
Am naa fi juróomi at. Juróomi at laa amoon fii. Juróomi at.
Léegi yow loo doon liggéey fii nii?
Police ñu doon liggéey nii rek loolu laa doon liggéey fii.
Ban façon ngi liggéey comme tooga raxas na la?
Tooga du raxas de. luñ dee sol di job rek loolu laa dee sol.
Waaw léegi yow bi nga nekkee fii benn tey nga fii ne feebar nga na dang de naan garab?
Dama demoon Banjul kenn yóbbu ma foofu suma ku nekk si suma papa léegi mu yóbbu ma foofu yóbbu ma Banjul yóbbu ma suñ kër la jógee mu yóbbu ma Banjul mu indi ma ba fii itam.
Waaw parce que dañ njëkkee yóbbu Banjul after ñu door laa isi fii.
ma ba fii itam.
waaye yow bi nga fi nekkee mbaa di nga am sa mbokk yi la dee seet si?
de suma mbokk duma dee ñëw seet si de ñu dee ñëw de.
waaye di nga bugg sa mbokk yi di ñëw di la seet.
ñëw seet si ma. waaw bugga naa loolu.
waaye ndax yow am nga doom?
am naa ay doom.
doom yu mag lañ na?
am naa neene Habi am naa baaba tam ma ko bugg a tuddee suma papa.
léegi waaye yow di nga buggoon ñooñu di leen gis sometimes.
waaw pour gis leen doon time gis leen.
léegi yow soo doon ñaan yàlla loo ko doon ñaan waxtu bii nii?
ma ko doon ñaan xanaa sëy yàlla may ma si doom loolu laa doon ñaan. sëy ma sëy yàlla may ma si ay doom mujj rafet.
da nga bëgg a am jëkkër daal?
waaw dama bëgg a am jëkkër yaaguñ maa yónnee guru tam de.
déedéet kay. dañ la yónnee guru?
dañ ma yónnee guru yaaguñ maa yónnee guru.
ok kon léegi yal na la yàlla mutale may la li nga bëgg a sa xol. waaw looy ñaan bépp jigéen ak bépp nit boo xam ne mu ngi seetaan programme yi pour affaire yi ñaanal leen rek koo xam ne yaa ngi am feebari xel bu demee noonu loo am pour ñaan leen.
ma ñaan leen rek ñaan leen yàlla may wér rek may ñu wér mu nekkam boo leen jullit.
jërëjëf yow tam ñu ñaan la wér ak wér la dégg nga.
ok assalamualaikum mbaɗum mba kon toon na nde toon baba manelti mo nosolto min ɓe dow kola TankaTanka Psychiatric hospital nin ko TankaTanka Psychiatric hospital wala loptano dami yal ko dal meli sondo me courant soto ikelandi wolto hadum fane ke jara wala fananto ni ajibe na doko fanna ni ajibe asiyatale aba kono komin ko ka personal topoto nin ko personal topotoro kono o ni yajibe wo kono fano tabakele abol kono nin personal nata mbe e tubal kamuna ka receive mbe bisimila na nyami loptano to ki ijube hani docteur o safero ka kinan fon fan sen na kiskisoro ke sondo meola karola ka jube abo kono le adum fanan abo kono mbe personal jata kende a topoto la nyaadil personal nin somanda keta fono keta mbe kumanda nyami ne lafta kate ku ngata ngeku nieku ngela bayol falingela nin domor wato sita nge kumandi ye bulol ko janni be domoro kela ni pareta domoro ke nin bordi mi wato sita nge kumandi momo tola den nga borodi la anim fana mbe jaral dol mul kela kantu ngaje ko abe manke bor jarol damanti ini si ini kacha be jarolo konol ini si ini ya hakilo jamfani komi ko kimira kol mina men kadna e nyin sono me courant ke tora bake tubal kam ko diversional therapy mbo fana kele nyami ko fana beke jane ini si ini football ke abe kono fana adum fana benna do ko fana kono kajibe mbe jinio ni ko jinio stavol melo me yanko mel ben tafane duma mbukol fana supervise la nyami ko fana bebe na do ko ni ajibe komi ko do ko nyinemu kantu ni tara foy ko lafta ka do ko nyi aerial to tubal ka fo nyaade the passion have to be there la fo nyi nyanta tar la jel ni mo ni lafta ilafta la do ko la ise do ko ke no tumomo ne ibe la fidala so kamala ay sabaro nyinin kale ay munyo fana nyinin ka komin ko yafu nyami yes of course ni ajibe hani mo ke non bantra prini ye tama ñom fe aka kolyale saka mom yanko fatar fay suno me courant sot fo se munyo ke fe wada ka kolyale dolbi je ningol kumandi ka fo ngana lafta ni dam si ngadiamu aka kolyale dobi ni kumandi so wala ko lafta purete ku aka kolyale dobi ni yol kumandi ko lafta nga kacha soto like muni mula problem oti muna na yamra ni tar so kon ikamuru nan kota ke o kacha sifalu do wada ju aka kolyale kando tumo kata sondo membe daming o tumo like kata abe sasaring so kamalo aka kolyambule watu do okay madam mama ilo nyini karo kuma tabakel kantu womu area ti me yanko dal na jero kata wol kon bake to bawol kam like na attention ka focus wol to bake kantu ni ajibe nying sono me courant me yanko dal amanki kafo malira be nyami ni moya soto ni taro loptano to ye jara akabane fereng hani kiskisoro yaitani hapo dobi je me yanko dal ke moko danto bi je me yanko dal wol dodo ni wol tara foy loptano bula ite bortala kotake iman sora borora kodake dolbi me yanko da ni wol tata fo se continue boro to wati fo wati jang ya bula but dobi je wol do ala de maro ni wol do fotara fo boro commencer wol fo jani ibe dan kune mariola wol nyata ka boro continue so family nyata ko le longe fe ka je ko nyimu kura me yanko da ni kura ndol fatata ni ajibe sono me kura ni motara fasoto o tumolon asolata ila de maro la katambi dina nunto e ka de maro di ala nyami kantu ni ajibe ma nyato abakela imanyana ka mutafe kantu iban ko kom ko kuron bala wala asabu so jama kaminda no family bu wolo bari on bu wole munyiti kom nim motata fo ngabula ntel ngana kato munke wolo ntel benna kato munke wolo ngaji be mbama ko nyami fo aya fansor na aya fansor amurta sokon ning anata sokon amamborota ning anata sokon natra marika mafiono ma amurta ka nata steresol ka ko o be nata amurta sokon be murta na ko teke fo sasa nyisina mbe misalo dile la mama kaniko komi ko nimo malire sor anata docteur la jar fakinet amuta sokon abuke la sanki yokot abuka bon kon esprit susulal bije wato wat fo malire si murna ko teke so nyin sasa fana bon nyam mbe misalta komi ko jama fo ninkol me yanko da wolle kam mafion ma ni ye mafion ma isonome courant so inata tanka jam ntel ngana ala tala de marto jararo so fo kende murta sokon ni murta mafion ka sasa ka murnan bar ni mafion mut ala de marto akata wol nyam so on ka famille dal mena wolem ni nata ngamute fe wado e kaji pesino kana sokon wala kuranto kana sokon ninga bula fatar fa fansoro fase do ko commencer bari bajele aka men soro abuka siya abafle sometimes dolbi yamanta dokula kafo ning lafta katana an kaf me ko appointment ning ye bula docteur fo se muru docteur te jube kafo ila boro fabe boro talalal ban fabe boro la falal ban fabe boro la falal ban fo da be kuntu la boro totally kolon kafo to total winning from the medication pour boro nyimbula ibajela wado ni nyanta kata appointment lo hani paso buka sonno adu momanta dokola comme ni banjul pasolem dobi ka bona fo bolon kon kanana ni man pasor ititano jama ko ta ko le bul bakel wado fanam je nim patient na so ikajen ka mo fo admit jam fo ngabula ni family call ikama ka fo maw marilo wala ntina kamonol alin so fo lokum fula hani jamman ke dami yan ko tardulalem amanken telephone sawt patient katan buljan nder sound nzino ni nata janto ni e fanso don ye say suwokon bar somta patient kata jang ye family kumali family te sona kana kam ye family kumali ye nay patient samba sokon ite demardi la patient demaro me ko patient sota wallahi mama patient do minita ni oltar sokon ye tari ikela dami fo se kumbo kantum ibaltiol kabore bare nyanta kamel lo wole mu bintel be position munto nyanta kalon ko nyim pesino le bije kunu so bitel be dami nyi loftano samanteni te be se sarno nyindularo family nyanta kanyina ha faham pesino amanke itele nyine sang sural kafu nyani li jombut ken bi itelia soro samantel sa sorno nyanta ko le faham jo no individual is immune to this illness itelia soro nyami samantel sa sorno nyanta ngole mufte ko ko bintel ngi muta nyami nyanta kamira sama ninga so lafta mole muta nyami bi ngi fana muta nyam so ka family dan wala ka society dan wala nga nyom makoy nyin sasa to la ko kan duniyaji be melbe be stirito kam ibe boto kordale kono amanke mo bije be stirito kam pamane hani yes sasa aboto kordale kono nin komi ko like family yele patient muta wala yesamba jarolo firile ko fenjo ni na tanka ja wala tar polikini bu ko fenjo foni bore même soro to nya ko sa fieta yo sang but fem so day kawdila mu firilet so patient be stirito ko boto kordal kon nin kordal te responsibility patient ya mako ala de marum be stirito ka be talala bakel membe murna tanka be talala bakel so wala nan ka society dal ka family dal le wate tubabul kamru ka fo like voluntary admission comme milan ko yaji to nya na courant wultan lafta kata tanka kade maro nyini wolun ka fo all the time tubaw saf nyini you welcome kandu nyaji be courant no meyan ko da like iya nyata kuntute wati mina juna nyami otumo la ke mako bar nyabula fatata a wajabita abine batandilal ya famle kafo ko kafo ibe mallale stigma whatever bula koma itela jata kenda ite bolnoma molbe mum fola molbe mum ijibe la nyami molbe chodi la nyami kana ujube kurano me yan ko da ite ma sang ala le aday kan so kamala makoro nyini mba fona momo yan ko itata tamanser yoje fambala ngalo maybe aliya discourse le aliya yoje fambala dukata tay makoro nyini as a terreno nyami ni nata jan you are welcome ni tar polyclinic in Banjul you are welcome mo jama bi me yanko dal ibe la motol boronda bi me yanko da ibe high position to me yanko da they are lecturing today me yanko da they are student and very intelligent student in any admit Janneh so ite kana ujube kafu ni tada molbe mun fol hani woman kumaya sama nin courant tar fa wajabte molbi na mun fol nyante mira la wala bar kafu bi nin tada de mar molbe mun fol kana ujube imare funtinan yana de maro nyanta ka nyamin adu inshallah ibaso le nyanta ka sunu nyamin.
Research has shown that basic knowledge about our health in the Gambia is poor. One of the contributing factors to poor health is people's lack of knowledge about their health. QTV brings you a weekly health program called Werwerle. Every Wednesday at 8:30 p.m., the show will look at different health issues